Welcome to a special edition of the Experience Darden and the Exec MBA podcast. I'm your host, Brett Twitty. On this episode of the podcast, I'm excited to share my recent conversation with Professor Dennie Kim. Dennie is a member of the Strategy, Entrepreneurship, and Ethics faculty here at the Darden School of Business, and he was our recent guest on our ongoing Office Hours conversation series. This is a joint series hosted by the Admissions Office as well as Darden Ideas to Action, and during this conversation, Dennie shares insights about U.S. healthcare, challenges, opportunities, and so much more. I think you're going to enjoy this conversation. So without further ado, here's my interview with Dennie Kim. All right, Dennie. Big question here off the bat. Who are you? What's your background?
Sure. So my name is Dennie Kim. I am a Korean American, originally from Brooklyn, New York. My family, my immediate family, my parents and younger sister still live in Brooklyn. My partner's actually based in The Hague in the Netherlands. She's an international lawyer. So it's been about a year and a half since I've seen any of them. But that's a little bit of where I'm from. Most recently, before Darden, I was doing my PhD at the Carlson School of Business in University of Minnesota.
All right. So what led you to Darden?
Oh, boy. Well, if some of you may know about the academic job market and how difficult it can be, Darden was a dream school for me because there were very few really top research universities in the world that care as much about teaching as they do about research. And so when I had the opportunity to interview here, there were several connections from Minnesota as well. I knew I had to, give it my all and really convert this one. And, I got really lucky.
So you'd mentioned this passion for teaching that the faculty at Darden have. How did you discover that you wanted to teach?
That's probably back to childhood. I think maybe those on the call who can empathize with maybe not being the most athletic or, kind of nerdy. I used to tutor friends and help them with homework just to, that was a way to build social relationships. And through that, I realized that one, it helps me learn to try to communicate information to somebody else. But I really enjoyed seeing people improve at something or kind of get through a wall that was previously standing in the way. So I discovered that pretty early on.
And there are paths that people can consider, right? So teaching is maybe one of them. Are there any other alternate paths that you considered before deciding, what I want to do is be a faculty member and teach?
Yeah, that's a great question. I, for a long time, thought I was going to be a medical doctor. And I was pretty dead set on that path. And then if you ask me now, if, I could pick any other career, it may be something more creative, maybe in the culinary arts. So being a cook or, helping to run a restaurant or some sort of food service establishment. Either that or, maybe start my own whiskey distillery.
All right, I got to ask about a follow-up question about the cooking. I mean, what got you in? Is that something you've always done? Is that a pandemic hobby that's accelerated?
I wish I could say it was. It was more born out of necessity because both of my parents worked. And so you pick up a little bit of basic culinary skills, from myself and my younger sister after school. And then that jump started in grad school. So when you're a PhD student, you got to learn how to survive.
Is there a meal that takes you back always to being a young kid in Brooklyn or being a PhD student, a broke PhD student in Minnesota?
Yeah, it's definitely Korean, which is very similar to Japanese style, but Korean curry over rice. That's you bake a big pot of that, and that'll last you a week.
You got to make it stretch, right? So,
Oh yeah.
So let's get into what you teach here at Darden. So one of the
Sure.
things that's been fun on these conversations is to talk with faculty about what they're teaching, why they're teaching those classes, what they're excited about when it comes to working with Darden students in the classroom. So what are you teaching?
So I teach first year strategy in the core. So that's typically the second quarter, right in that time where everyone's busy recruiting. So it's a busy period. And then in the fourth quarter, also first year, I teach an elective on strategic analysis and consulting.
What, how did you come up with the idea of strategic analysis and consulting? What brought you to teaching that particular class?
So I used to be a strategy consultant. This was immediately after undergrad. So it's, I guess, a line of work that I'm very familiar with. Also, it's one of the most popular career paths for Darden students. And when I joined, our colleagues told me that, hey, look, there's a need for this. Do you think you can, teach something like this? And I, after doing the 2 years now of the course, I think, yes, absolutely. This is something I can do, something I really enjoy. And I think it's valuable for the students.
So what do you do in that class? I mean, what kind of cases are you reading? Are you doing things beyond just case discussions? What does that class look like?
Yeah, there's about half of it is almost a continuation of first year strategy. And that is, to build additional repetitions. So for those of you who don't know, a quarter at Darden is only 7 weeks. That's not a lot of strategy, and we feel like you can, well, especially with Q3 in the middle, you get this break. So quick refresher, let's hit some more strategic analysis topics in the familiar case-based discussion. And then once we develop some better skills or deeper understanding, think about it in a more applied setting. So how that might translate to the job.
All right, so you came to Darden intentionally, the focus on teaching, the emphasis on teaching. What do you enjoy about being with Darden students in the classroom?
Darden students are, one, they're just good people, I find, which is always very helpful. So they're very supportive, I think very adaptable. But for me, what makes it fun is that they're very intelligent, very motivated, and very passionate about the academics, learning. And so that keeps me on my toes. They ask great questions. I'm always trying to think about not how can we have a perfect class, but what can we discuss today that maybe a year or 5 years down the road, they'll think back on this and be like, yeah, like this is starting to click now, right? That sort of mindset of being a lifelong learner. I think that's super cool, and that really speaks to me.
What does it look like for you when you prepare for class? I think one of the interesting things, obviously students talk a lot about the work that they do to get ready for
Yeah.
class, but one of the things that's interesting when I talk with faculty is they're doing a lot of work too to get ready for that discussion. What does that look like for you?
Yeah, it obviously depends on the class, but let's say for a case discussion. So in addition to obviously reading the case, and some cases are ones that we've written or helped to write, we are basically trying to go through what the class might look like in my mind, and I'll board out what the boards might look like in a real class discussion. We're pretty scripted in terms of like dedicating some amounts of time to different parts of the discussion, but we fully expect and almost desire things to kind of go off the rails. And we use our sort of prep and our teaching guide to make sure that we can bring it back and hit the important points. But there is a lot of there's a lot of prep for each.
Was that new for you teaching in the case method? Had you taught case discussion based
Completely
classes in the
new.
past? Completely new. Okay.
Completely new for you.
How did you get up to speed?
That was one of the best things about Darden. Not only was there some formal training and some like teaching seminars that I could attend, but the faculty here, my colleagues were so wonderful. about inviting me to their classes, allowing me to sit and observe. And that was really something that helped me a lot. You can observe some of the best professors in the world teach and ask them questions about like, hey, why did you do this thing? Or I noticed this happen. Was this intentional or did it come off the cuff? And having those discussions with colleagues has been super helpful.
Well, let's talk about your research area. So you mentioned that for a long time you thought you were going to be a doctor and were thinking about that path. And I wonder, did that sort of shape your interest from a research standpoint, what you look at in your work?
Yeah, 100%. So even as a consultant, I was focused in the healthcare industry, so biotech and pharma. Then I spent some time working at Brigham and Women's Hospital in healthcare administration, mostly in the surgical services. And so a lot of my research is focused on understanding the healthcare system, the problems that it faces, ways in which organizations can collaborate or innovate to improve healthcare delivery or patient outcomes, things like that.
And you've also done a lot of work on networks and looking at
Yes.
networks and healthcare. What do we mean when we talk about networks, or what do you mean when you talk about networks?
Yeah. So most everyone is probably familiar with the term social network, but the idea of network analysis is that whenever two entities interact, they can form some sort of relationship, or we can map an interaction. And as that's true for individuals, we can also do that for organizations. So as organizations, in my case, share patients or refer patients to one another, they create these massive patterns that sort of describe the way that patients move throughout a healthcare system. And that's just one example of a network. And there are obviously networks in the physical sciences or in chemistry, mathematical networks, engineering networks, like electrical. So all coming from a similar place, but in the sort of social sciences, those interactions are us communicating. Maybe we went to the same school, we went to the same workplace, and understanding how those patterns of ties and relationships can influence our behavior or affect or limit our ability to achieve certain goals. That's sort of the way that network analysis applies to my research.
It's an interesting sort of social science layer to looking at healthcare delivery. What do you enjoy about that human element of things, looking at how people relate to each other?
I think for me, just relationships are business, or business are relationships. I think so much of the world, as we all know from living through COVID, the absence of certain types of relationships, certain types of interactions can be massively impactful. And so for me, the relationships are a really sort of fundamental aspect of our society, transactions, social interactions, and then the ability to measure and perform computational analysis on that is where I see, some of the science or the math interacting with more of these qualitative aspects, the way I see, what's important in the world.
All right, so we've gotten through the introduction section. So this is where we're going to start moving into topical questions. Obviously, for our attendees today, Denny's background's in healthcare. This feels like a time where, healthcare is top of mind for a lot of different reasons. And so, Denny, you wrote an Ideas to Action article last year, kind of looking at a post-pandemic future. And I wonder, in your opinion, how has the pandemic highlighted issues, challenges with the U.S. healthcare system, maybe even exacerbated some of those issues?
Yeah, and I would be remiss if I didn't shout out the Ideas Action team and our folks here at the IBIS, the Institute for Business and Society, for helping put this piece together and helping me sort of collect my thoughts on this area. A lot's changed since the time that article came out. I think the one thing that is not surprising to anybody who studies the healthcare system is that the pandemic didn't really fix any problems. It obviously created new, very important problems for the healthcare system to solve, but it has illuminated some of the deficiencies or weaknesses. I think most importantly for me, from my vantage point as a researcher, is looking at the fragmentation of the system. And so when you hear stories about capacity at one hospital and a few miles away, they're overflowing. They're, patients on beds or stretchers in hallways, and the lack of communication or the lack of efficient structures to be able to allocate those resources efficiently. That's an issue. And I'm not saying that's unique to the US healthcare system, but it seems like something that we should be working to solve. And unfortunately, I think there are many obstacles preventing that from happening more effectively, sort of on a national level. I think there are pockets where it's done very well, but we don't necessarily just want to celebrate those successes. We want to make sure that we're getting everyone, we're raising the floor across the board to make sure that everyone is, got fair and equitable access to good services.
Denny, one of the questions that we got in advance was around organizational design affecting healthcare delivery. And it seems like that's something that you've spent some time thinking about, particularly given your work on networks.
Yeah.
How have you seen that sort of organizational design element affect healthcare delivery in the US, abroad? It seems even to relate to the comment you just made.
Absolutely. So the word design is one of my favorite words, both just on a personal level and also as a researcher. I think design principles or design thinking is a really powerful framework and a really powerful mindset. And we like to think that the things that we interact with, be they objects or institutions, we like to think that there is some grand plan and that there are designers behind the scenes working to ensure that things are optimized or things are, well designed, let's say. I think one of the things that we realize very quickly about the healthcare system is that it is extremely complex. So even something that sounds complex, like organizational design, is just the tip of the iceberg, because more so than simply organizational design, we have to be thinking about interorganizational or network design, or the way in which communities design this sorts of infrastructure that's necessary. So I would say on the organizational design standpoint, healthcare is not where we would necessarily look for organizational design innovation per se. Not to say that doesn't happen, but it is a highly institutionalized setting in which there's lots of regulations and really structures that have been in place in terms of hierarchy or the way things are managed, the way things operate, that force the organization to adhere to certain ways of doing things. And so that really constrains the design process. So when we think about, we don't often think about like building a new hospital from scratch and redesigning the way in which the healthcare system works through just that one hospital. And I think that's what makes healthcare reform and healthcare improvement so challenging. Even if you build a new hospital, that hospital has to interact with all other parts of the existing system. And so when we're talking about design, we're really talking about redesigning these networks, redesigning the infrastructure or the processes, the supply chains that are in place. And that's much harder for a single organization to solve.
So one of the perennial topics here in the US has been around improving healthcare. It certainly feels like it accelerated post-Affordable Care Act, but
Yeah.
talk about it. And as you know, the pandemic has highlighted challenges, deficiencies. Do you feel like we're making progress? Are there things that you could point to that say, you know what, here are some things that I think are glimmers or examples where we are improving healthcare?
Yeah, we're definitely making progress. And, that's in large part due to the fact that there are thousands of very dedicated practitioners, physicians, nurses, non-clinical experts, researchers, academic. There are people, stakeholders all around the system that are very, very passionate. They, willing to take big pay cuts, to do this work because they truly believe that this is necessary for society. I think the Affordable Care Act, when it passed, more than a decade ago now, it was, whatever we think about the actual, nuts and bolts of the policy, and it's a very complex bit of legislation. What it did that I thought was just positive, absolutely positive, was that it thrust that discussion onto the national stage, where people were starting to talk about, hey, the healthcare system might not be that great, or like, yeah, these problems that I encountered when our first child was born, like maybe that's not just a one-off. Maybe this is a systemic sort of thing that people can be talking about. And so I think that alone helped to move the needle a lot, just making this a topic of conversation. But there are lots of innovations that are happening at the state level. I think, despite the fact that we are a predominantly privately insured through employers system for the majority of the under 65 population, the fact that we do have Medicare at the federal level, Medicaid, and other sorts of, I guess, government-run support at the state level, that gives us some opportunity to run some interesting experiments. So there's some really innovative things that have been happening in states across the country. And then, like one of the contexts that I study, the Medicare Accountable Care Organization program, as well as other sort of similar value-based payment systems that private and public insurers are running, that's really great innovation. Like these ideas were put out, maybe the genesis of ideas are more decades old, but really the language of value-based care and ACOs, something that was, percolating in the early 2000s. And, better late than never, but we're actively trying these experiments, collecting really important data, understanding how we can save money while not compromising the quality and the sort of efficacy of care that we're delivering to patients. These are all really, really important improvements that I don't think would have happened if not for the work of, many of the people that I look up to and cite in my papers, really, really pushing for change and the need to have this discussion.
Do you think that there are global examples? So outside the US, when we talk about improving healthcare here in the United States, oftentimes people say, well, look at these countries, look at these other places, look how they deliver healthcare. Do you think that there are countries, examples that we can pull from as we think about improving healthcare here in the United States?
Yeah, so I will caveat this by saying that my understanding of global healthcare systems, especially on the payment, the reimbursement side, was much deeper about 15 years ago when I was a consultant in this space. But absolutely, like this is without a doubt, I think one of the most important things that we need to do, but any country. And so, for example, when in 2007, that was probably the first time I really fully came to grips with the fact that there are systemic problems in the healthcare system in America that require business solutions, not just medical solutions or public health solutions, but real business solutions. And a lot of the examples that people gave, they would contrast what's going on in the US to places like Canada, Australia, the UK, and then more recently, I think, with COVID, what happened in South Korea, Taiwan, some of the Asian countries that are smaller, maybe more homogeneous population, technologically sort of sophisticated. And while I'm not saying that we should look to those countries and kind of import over or just copy paste, I think we would be at a significant disadvantage if we didn't observe what happened there, understand what are the sort of social structures and the sort of incentives in place that made something work, and what are the deficiencies, what are the obstacles that they faced, and use those learnings to apply, maybe if not at a national level or even a state level, at a community level, right? So like healthcare systems in a community or a region can look to those examples and see, is there something that we can borrow or can we implement? Great example is that I know the NHS in the UK takes a lot of heat for, this sort of putting a cost on the value of life, but really they set the stage for us to be having these important conversations about, is it worth it for a society to spend millions or tens of millions of dollars on drugs that are not necessarily going to improve a patient's quality of life, and may only extend their life by a month or two. And in the US, we think, protect life and save life over everything. But I think on a global stage, the fact that people are realizing, like, look, the cost of these drugs is too high. It's not sustainable to do it in this way. So either we force the drug companies to charge less, or we have to do something here to sort of restrict access to these very, very expensive and maybe unproven from an ethic or a cost benefit standpoint therapies. And I think for us to listen to those conversations and figure out, where we're going to sort of draw the line, that's crucial. We cannot just shut ourselves off to learning from other countries, because at this point, the evidence is very clear. We may be the leaders in terms of innovation. And I mean, the COVID vaccine is a clear example. We have great access to these vaccines because that innovation and that research was done here. But in order to benefit from that and to benefit from the amazing resources and institutions that we have, we also need to recognize that, like, going from that point to good healthcare for all Americans, there are a lot of problems, a lot of gaps within that. And so we shouldn't be paying more for worse healthcare, right? If that's what we're, if we're trying to say that the US healthcare system is the best in the world, we need to do that on all metrics, not just we have the best drugs or, we have one of the best hospitals in the world.
So Denny, I'm curious. I want to come back to a comment that you made as you started off. That answer is in maybe 2007. You said you realized that business was a really important part of the solution. What led you to that conclusion?
Well, it was very simple. So this was a class I took in my senior year at Harvard called The Quality of Healthcare in America. Quite bluntly, it was run by former head of the Centers for Medicaid and Medicare Services, Don Berwick, Warner Slack, and David Blumenthal. So really just leaders, visionaries in this field of pushing healthcare reform. It was actually run in collaboration with the Institute for Healthcare Improvement, which Dr. Berwick helped to start. One of the speakers that they brought in was Dr. Jim Kim, who president of Dartmouth, ran WHO. I might be misremembering that, but Dr. Jim Kim, he gave just a fascinating talk, and I had an opportunity to chat with him briefly afterwards. And I mentioned to him that, like, I'm very interested in these big, messy problems in healthcare. And I asked, what sort of training do you think, would help solve those problems? And he asked me what I was doing after college. And I told him I was going into strategy consulting in biotech and pharma. And he, his eyes kind of lit up, and he said, good, like, we need people, we need consultants, we need people with management experience who know how to lead teams and to develop projects and execute things. That's what we need on a global stage, to take care of these problems, because it's not just about being the best doctor or being the best, patient caregiver. It's about understanding these problems at a slightly higher level, and figuring out what are the incentives, what are the inefficiencies in the value chains that prevent our best efforts or our best intentions from translating to, better outcomes for patients and community. So I sort of credit that class and that conversation with him for really convincing me that, like, hey, maybe I'm not completely selling out here, that this next path for me is going to be very impactful for the work that I want to do in the future.
I want to come back to another one of your ideas to action articles, one that you wrote about the rise of retail healthcare retail clinics and healthcare delivery here in the United States. What got you interested in this particular topic?
Yeah, that's really interesting. So the genesis of the paper was a water cooler conversation that I had with one of my mentors at the University of Minnesota, Gurnita Vasudeva Singh. she had been working on just collecting some data on retail clinics with a colleague of ours who was at Johns Hopkins, is now in Toronto. And well, retail clinics in the US started in Minnesota. And so in 2000, the first one started in Minnesota. And it was just a very interesting thing from a theoretical standpoint. So it was a new industry is emerging. And it was an innovation in the sense of in organizational design, in that now all of a sudden we are designing these clinics to live inside supermarkets and big box superstores, to provide more than just the basic flu shot, to actually provide the basic primary care, primary medical services that you might normally go to a nurse practitioner or a primary care physician in a private practice or in a hospital setting to address. And we took a really strong interest in that, because how often do we see sort of, I guess, new organizational forms or new industry emergence kind of in the healthcare setting? And because of my interests in healthcare and my co-author's interests in the sort of institutional changes and the sort of evolution that happens amongst different types of organizations and organizational fields, that was sort of the genesis of the project. I think coming full circle with the Ideas to Action article, I've been a customer or a patient of these retail clinics since my time as a grad student in Minnesota. And I think for many of us, these retail clinics were in large part how we got care during COVID. So not only did they assist with testing, but they provided web or telemedicine services to help with diagnosis or providing consultations, and then now with vaccine distribution. And it is a fascinating thing to see the retailification of some healthcare services, something that traditionally has been so guarded and protected by the traditional medical establishment, to see bits and pieces of that slowly start to kind of become more commercialized or maybe commoditized, in a sense where patients are now, it's now no longer such a hassle right now, to this day, you sometimes have to pick up your phone and talk to somebody to make an appointment. Here, everything can be done electronically, can be relatively seamless. You can walk in many instances. And so I think this trend will continue. And so for us, as we started looking into it more and more, we thought this is probably, part of this new evolution of some aspects of healthcare, in which maybe patients will take a little bit more ownership of their health management, because some of these things are easier to do now. They don't necessarily require expert knowledge, expert consultation for everything.
So I take it you see that as a real positive development from an accessibility standpoint, people maybe being more engaged with their personal health.
Absolutely, I do. I think one of the real issues in healthcare, and this is not a US only problem, this is a global problem, but one of the real issues with healthcare is, or medicine, I should say, maybe more specifically, is that there's a huge knowledge gap or information asymmetry that we as patients, I think, are conditioned to believe that we are not sort of in control of the diagnosis and treatment and management of our health conditions, that we go to these experts and these experts tell us what to do and we follow their instructions. And I think the more that we break out of that mindset, and that we treat the physicians as, yes, they're experts, but we are partners in their ability to manage and treat our ailments. The more we take ownership of that, and the more that, physicians see us as partners as well, and not just non-compliant complainers, who come in once a month and, they have to repeat the same instructions again, like, make sure you do this. And then they kind of expect that patient is not going to do that. The more we can change that sort of relationship, change that dynamic, I think the better off we're going to be.
Let's talk about mental health. This has been certainly an ongoing conversation, much longer than the past year. Access to mental health resources, counseling, um, having people sort of tap in to networks that can support them. But this past year, it's really accelerated this conversation as people
Yeah.
have had to socially distance from others, may not necessarily be around friends and family in the same kind of way. So I wonder, do you have any thoughts on how we might address what is a growing need, is a need that's existed for some time, it's really expanded in the past year? How might we provide more counseling, more mental health services to folks?
Yeah, and the mental health aspect of this is something that I care deeply about, both from I guess a personal standpoint, but also thinking more in terms of the business or the efficacy of our healthcare system. On a personal level, I think for myself and everyone on this call, we felt the sort of negative effects of COVID in some way, that sort of isolationism, or even if we're constantly on Zoom, constantly talking, just that lack of being around our friends and family, or even just the people at the grocery store, right? These masks and not being able to interact in the ways that we normally do takes a significant toll. And one of the issues with mental health is that, well, maybe more than just one. There's a stigma attached to it, and I think that has fortunately gotten much better over time, especially as for better or for worse, celebrities, professional athletes, people that have more of a public stage, they've become more outspoken about their struggles with these issues. And I think it's allowed, especially young people, to feel more comfortable, just acknowledging even for themselves that maybe this is something that they need to deal with. The other aspect of it, though, is that mental health and healthcare in general, but especially mental health, is something that is not equitably accessible, right? It's something that maybe those of us who have more privilege, more economic resources, the luxury of time, that we have greater access and awareness of. Whereas I feel like perhaps those that mental health services could help the most are those that don't have those things right now. And I think that even the awareness that this is an issue that can be not necessarily treated, but managed, and that taking ownership of mental health can be a performance enhancer. I think that sort of awareness is not evenly distributed throughout society. And I truly believe so. On more of a personal note, I've used mental health services for a few years now, dating back to my time in grad school. And that's sort of the way that I have treated it, that it is, in some cases, it's necessary. In some cases, you're going through a time and you just need to access these opportunities and these experts' ability to listen and counsel you on certain issues. But on the average week, it's almost like going to the gym, right? It's an opportunity to sort of exercise that part of your brain and your sort of heart that you may not have the capacity or the sort of leeway to on a within the normal day. And so for me, I always encourage friends, family, students that, like, hey, if you haven't thought about this, you might want to try it out. Like, I significantly believe it's a performance enhancer.
So if you were leading a healthcare organization right now, what would you be thinking about? What would be
Oh yeah.
on your mind, Denny?
Yeah. Well, I mean, obviously in the immediate term, we're dealing with COVID and trying to figure out a lot of the things that I mentioned earlier on. So like, how can we, so one, right, if you're working in an organization, your first priority is that organization. So how can we make sure that, we are using our resources, both the sort of physical infrastructure and our people, to the best of their ability? And again, how are we making sure that we're taking care of our people, making sure that they're doing okay, because that's the organization. But really, I'm thinking about how can we work better with other organizations, right? How can we leverage the sort of collective resources of our community, of the system? And then I'm thinking about ways in which we can use technology. So that has been the other, massive change over the last year, is that telemedicine has now that's become commonplace. And so like when we say telemedicine, right, like sometimes I guess the history of that term even is just like phone consults, but using Doxy and using the video conferencing, using phones and different apps to assist in diagnosis and to provide more detailed clinical information to physicians and other practitioners. I think that's amazing. And as if I was leading an organization, that would be one of the things that I'm really trying to explore and really trying to get ahead of, because not only has COVID accelerated this, I think it's created this opportunity for us to experiment a little bit and really figure out, like, are there things that we can change right now, in the midst of all of this, not necessarily chaos, but in the midst of all of this flurry of activity, can we maybe sneak in a couple of, innovations, or maybe try out something that, maybe otherwise would have gone through layers and layers of bureaucracy. Is now the right time to sort of push for something or make an investment in some new R&D or some new medical tech? So that's what I'd be thinking about.
A little bit of a follow-up question. This comes from the Q&A, and also may involve a little bit of prognostication on your part. So hopefully you feel comfortable breaking out the crystal ball for this one. So what lessons do you think that the U.S. healthcare system, healthcare organizations might take from COVID sort of going forward?
Oh,
do you think there's things that when we look back on this experience, these are the things that might stand out?
Yeah, well, I think the most basic one is pandemic preparedness, right? So incidentally, when I was a consultant, one of the projects that I remember working on was developing forecast models, and it's sort of basically this sort of pandemic scenario planning exercise for a client that was involved in the development of drugs and vaccines for the flu. And so we talked about the fact that governments tend to have stockpiles of these things, and oftentimes their stockpiles expire and they don't realize these things. And so I think, one, this has heightened awareness that, hey, something like this could happen. And now that it's kind of top of mind, I think people are more likely to believe like it could happen again. And so there will be better pandemic preparedness planning, both at the national level, state level, but then also just individual organizations or healthcare systems. I think that's first of all. Number two is, I think we are going to recognize more and more the need for integration among healthcare organizations. It's never going to be perfect. Like I think we're a long ways away. And I think in some ways it's almost impractical to suggest that the entire US be one integrated system. It's going to be incredibly difficult to achieve. More realistically, I think on a more regional or community level or a state level, better integration there, interoperability of electronic medical records, for instance, the ability for patients to easily access their electronic medical information, or to have their information be electronic in the first place. I think these are things that will hopefully be accelerated, because, I mean, let's be honest, that those of us in the US who have been vaccinated here, we have a little piece of cardboard that someone has written on in pen. It's not protected in any way. And that is our only proof of vaccination. It can so easily be counterfeited. It can so easily be manipulated or destroyed or lost. That we shouldn't be satisfied with that. We shouldn't be satisfied that we have to carry around a piece of paper in 2021 when we're doing all of this online and on Zoom, and cryptocurrencies booming. Like, we're in a very digital age, and there's really no reason why this should be acceptable for the future. We can understand, right? Maybe it's a stopgap. It's the best way to do it, most expeditiously. But in the future, we can do better. And so I think we will. And I think this experience has shone a light on the fact that we are behind the times in many ways. Like the time of paper records and the time of mistakes due to these traditional ways and the inability for organizations and people to change, that's got to go.
So, question about your work with Darden students. I imagine those students who are really passionate about healthcare may seek you out and want to talk to you about your background and also maybe take your class.
Sure.
How have you seen Darden students who are passionate about healthcare get engaged with this work, either while they're at school, in the summers? I mean, what do you see?
Yeah, that's so I've only been here now 2 years. But even in the last 2 years, I've been pleasantly surprised to see the number of people who are, coming from healthcare backgrounds or are, very passionate about doing work in healthcare. I think it's increased, or at least maybe, more of them have sought me out, or I've been able to interact with more of them. Um, Definitely, I think at the school level, there are more and more faculty now as well who have expertise in healthcare, who are very interested in either learning more or using it as a research context. And I think that's super interesting. And, for, let's say, for our residential MBA students, there's the Darden, the healthcare club. And I know that I've been in touch with a lot of the students that are part of that in ways that we can kind of expand the scope of their activities beyond just, organizing some speakers from industry to maybe have more of an impact, learning about things amongst ourselves. Or I've had a couple of students that I've worked with over the summers to help me on my research with accountable care organizations. I think there will hopefully be opportunities to engage with the local health systems here, which hopefully post-pandemic I'll be able to explore a little bit more fully. But so yeah, I think it's not the healthcare path or the healthcare track is obviously not as well established as maybe the one for investment banking or consulting, but it's there, it's healthy, and I think it's about time it's starting to grow, and I think there's clear signs of that.
I will say from the admissions end of things, we meet a ton of prospective students who are passionate about this topic, and I feel like it's really accelerated in recent years.
That's
And
great.
even this past year, with everything going on in the world, if you are coming to business school and wanting to have an impact, healthcare is one of those things that touches everybody's lives. Um,
Absolutely.
so you mentioned something earlier, and it relates to a question in the Q&A about this sort of way that healthcare works in the U.S. that we focused really on research development. And this is where the United States really shines on a global stage. Developing countries, you don't see quite the same level of investment perhaps in research and development. But you may see really robust entrepreneurial communities around other things, maybe finance, investment. But why do you think it works this way in the US and maybe it's a bit different in other countries, particularly developing countries?
Yeah, that's a really interesting, important, and very complex question. I'll do my best to try to give a short answer. And again, like by no means do I claim any expertise in why global healthcare systems are the way they are, or even in the sense of like the scope of pharmaceutical lobbying, let's say in the U.S. But so the short answer is money. The short answer, it really is money. The U.S. is obviously the biggest healthcare market in the world, and part of that is because our prices are extremely high. And part of the reason our prices are extremely high is that the government does not force companies; they do not price regulate, they do not price control. And so, while let's say individual insurers in the U.S. may negotiate with drug companies to have particular price points for different types of therapies, that's not enforced at the national level as it is in many other countries. And for that reason, that's the reason why people sort of tongue in cheek say that America is subsidizing healthcare for the rest of the world, because a lot of the costs of R&D are recouped in the American market. And so I think, that's really the sort of long and short of it, is that it's just money. And so also for from the perspective of an international drug company, one, the structure of the industry itself, and here's something that you would learn in core strategy, right? The structure of the industry is that you have these massive multinational, major pharmaceutical and biotech companies, and then you have your very, very fragmented pipeline of smaller startups or smaller, more specialized shops that oftentimes they do not have the resources and can never have the resources of the large manufacturers to market, distribute, run the clinical trials. And so that's why you see so much M&A activity in that space. And so for a international firm, like if you're really trying to, if it costs millions or billions of dollars to do R&D, you're not going to be able to do that alone, and you're not going to be able to recoup that investment without accessing the US market. And what's the easiest way to access the US market is to work with a US company that is already well established and knows how to, maneuver and play the game here.
So, Denny, what are you researching right now? What are you curious about? What are you looking at?
Yeah, so I'm continuing my research on looking at healthcare delivery networks, both in the accountable care organization space, but then with some colleagues and my grad school advisors in Minnesota and Michigan, looking at provider networks in the care of different surgical procedures. So my work in hospital administration was in the surgical services, and a lot of surgeons and people around the areas of surgery are really interested in these ideas of value and value-based care. And so we're looking at the ways in which we might be able to identify network interventions to where we can, make small changes in terms of like policy or procedure that might help reshape networks or understand the ways in which particular patterns of interaction might lead to some positive or negative outcome. So that's the main, sort of pillar of the work that I'm doing. And then on the side, this past year, I started to become very, very interested in blockchain technology and cryptocurrency, as well as some of the more, I guess, in the popular media these days, like the NFT space and marketplaces. And that originated because, one, I think there was a NBA Top Shot product, which I'm a huge basketball fan. And as a kid, I was a card collector. And so I became interested in that. But when I looked at what the data was, the platform and what was going on, I saw it as maybe a microcosm of what might happen in society as we think about the way in which our cities and businesses are coming back post-COVID or as people get vaccinated. So the idea that when we went into lockdown, there were all of these transactions and social networks that all of a sudden disappeared. And how resilient are these? How likely are they to bounce back in the way that they used to be? Or if they're going to come back in a different way, what are some of the things that help us understand why the newer or the sort of emerging networks look slightly different? And so my idea here is to try to collect data on these sorts of marketplaces where there's very detailed transactional information and then see what happens when these marketplaces, go under maintenance or, arbitrarily shut down for some random event, to see how likely are these sorts of networks of transactions to bounce back in the same way, or, if they look completely different. And so that's an area that it's still very, very early stages, but it's been very interesting.
Well, Denny, we've had 3 office hour conversations. We've had 3 discussions of cryptocurrency here, or at least references to cryptocurrency. So the streak continues. We've got a good question here in the Q&A about any advice you would share with someone who's pursuing an MBA, thinking about an MBA, and wants to go into healthcare. Anything that they should be thinking about?
Absolutely, yeah. So first of all, this is a piece of advice I got from my former boss at the hospital, is that if you are passionate about healthcare and you want to, especially if you want to do strategy or you want to do leadership in a healthcare organization, you have to understand operations, not surgical operations, but operations from a supply chain and ops perspective. Because if you don't understand the day-to-day, if you don't understand who's doing the work, how they're doing the work, how that impacts patients, then you've got your eye on the wrong target, right? So the same way in which in many industries we focus on customer centricity, in the healthcare space, it's patient centricity overall. And I think I truly believe that if you lose sight of that, then you lose sight of why you're in the healthcare industry in the first place. If you're just in the healthcare industry for the money, I don't know what to tell you. That might not be the best decision. I think there's tons of money in the healthcare industry, right? It is the biggest industry there is in the country. But I think that ops perspective is that you really do have to have a clear understanding of how this work gets done. And that means sometimes getting away from your computer, getting out of your chair, stop, when you have your spreadsheets, you should be asking yourself, where does this data come from? Or if I see this trend, what is it in practice that is causing this trend to look this way? And I think that's good advice for anybody, but I think it's especially important in healthcare, because if you don't understand that, you're not going to be able to communicate with physicians, with nurses, with other people who are on the ground doing the work. Like, they're not going to give you the time of day if they don't feel like you understand what their lives are like and how hard the work is. So I think that's absolutely important.
So any books, movies, anything you'd recommend for people who've come to the talk today and interested, curious, learn a little bit more about the things you've been talking about?
Yeah, that's a great question. And so I think a great place to start is Atul Gawande's books. And in particular, I think his book Better is a really nice place to start. All of his writing is really well done and very fascinating. It's a way for the average person to learn a ton about healthcare, but also to get a deep appreciation for the types of things that a surgeon thinks about. I mean, he was a surgeon at the hospital I used to work at, and he became so well known for all of these works. But it's just fascinating to see him just like walking through the ORs and scrubs, and you forget that like this guy, all of these learnings and these insights are coming from his practice in medicine, like his experiences there. And again, going back to the understanding the ops piece, right? The ability for him to generate these insights and have this broader impact on a global level, it comes from his deep understanding of what his work is and the constraints or the context in which he's working. And I think that's a fantastic place to start. There are other, he's got some other pieces in the New Yorker, and then the author Sandeep Johar. I think his first book was called Intern, or I may be confusing the two, but Atul Gawande, Sandeep Johar, those two authors, those two doctors really influenced my thinking about the practice of medicine and the healthcare system. And then I would encourage folks to try to see, when you're interacting with the healthcare system yourself, think about that from an organizational standpoint. Think about not just from your perspective as a patient, but your perspective as a customer. What were the processes and the structures in place, and really try to see the business in your daily life. And I think you'll start to see like why is it this way? Couldn't this be a little bit better? And I think that will be a great place to start.
Well, Dennie, I want to thank you for your time, your expertise, your energy this morning.
Thanks, Brett. Thank you, everybody.
And that was my interview with Dennie Kim, a member of the Strategy, Entrepreneurship, and Ethics faculty here at the Darden School of Business. As always, if you have any comments, suggestions, requests, anything you'd like for us to cover here on the podcast, we're all ears. We can be reached at Darden, that's DARDEN, at virginia.edu. Until next time, stay safe, be well, and thanks for listening.